You're listening to The Bob Zadek Show, a full hour of libertarian discussion with the smartest guests on radio. Live, spontaneous, and thoughtful. It's the show of ideas, not attitude. Now, your host, Bob Zadek.
Hello, everyone. Welcome to The Bob Zadek Show, the longest-running live libertarian talk radio show on all of radio. Thank you so much for listening this summer Sunday morning. In the life of the average American, there are two institutions that exist, or we believe exist, to protect and look after our self-interest and our well-being. Those two institutions are government, to whom we pay a fee to take care of us, and to protect us. The fee is called taxes, of course. And there is the entire medical healthcare community, who we pay through fees and premiums and the like. And when we pay the medical community, we expect one thing in return, that they will look after our best interests and protect us from harm, the specific harm of disease and illness and broken bones and the like. And that's a fair summary of the structure of life in America and how we are protected. What happens if those two major institutions, government on the one hand and the medical profession on the other, start to work at cross purposes, where they, rather than work together in their relative spheres, both to protect Americans, they work against one another so that the positive effects of one offset to some degree, and often a material degree, offset the good work of the other. Well, you don't have to speculate about that, because that's what's happening in America today, specifically in the area of addiction and opioid use. We have, on the one hand, opioids, prescription drugs in general, opioids in particular, which are prescribed by doctors because a doctor, based upon their knowledge of our medical well-being, they have determined, based upon years of study and their profession, that that is the right prescription for us, and we trust them as we should. But yet now we have government inviting itself into the doctor's office, into the privacy and the sanctity of the patient-doctor relationship, and the government saying, no, doctor, we know better. We will prevent you under pain of fine, imprisonment, loss of license. We will prevent you from doing what you determine to be in the best interest of the patient. Well, in that tension between what a doctor believes is best and what government believes is best, I leave it to you to decide who you're more likely to believe if you have a choice, but you do not. And this morning, to discuss the tension between what the healthcare profession believes is in your best interest and what government believes that healthcare industry ought to be doing, to help us understand this crucial tension. What could be more important than that? I'm happy to welcome back to the show my dear friend, Dr. Jeff Singer. Jeff is a senior fellow at the Cato Institute. He works, of course, in the Department of Health Policy Studies. And Jeff has a unique view of all of this, because Jeff has spent a great deal of his life studying both the political effects on the medical profession and the medical effects on the medical profession. Jeff is a practicing surgeon. He's the founder of Valley Surgical Clinics, which is the largest and the oldest group of private surgical practice in Arizona. And Jeff has been of late working, as I said, as a senior fellow at Cato, studying this issue. So Jeff is now learning even more and will share his knowledge with us on the often contrary pressures of government on the one hand and the medical profession on the other, both we believe committed to our well-being, but is that the case? Well, we'll find out this morning. Jeff, welcome to the show.
Thank you for having me. Good morning.
Now, Jeff, the subject this morning is not healthcare, because that wouldn't be the subject of a radio show. That would be the subject of a 4-year graduate level program, which we don't have the time for. So we have an hour of high quality, intense content radio to discuss the very specific issue. And we picked this issue because it is so much in the news and so profoundly misunderstood by journalists who write about it, by the audience of journalists who read it, by bloggers, and by governmental officials, that it is my hope that you can shed light where there regretfully is so much darkness. Now, first, there are words that get used all the time in the media, but without explanation as to what they mean. So let's do a little, just a very brief glossary for the minute. First of all, the subject this morning is opioids. Now, most people, I think, believe that an opioid is a very specific drug. It is a prescription. You can say, I would like to buy an opioid, but that's not the case at all. So, Jeff, just to have the audience follow our discussion, tell us about what an opioid is and how that meaning is misused in discussion in the media and in the press.
Okay, well, opioids refer to a very broad category of drugs that have some relationship to the opium plant. So there are opiates, O-P-I-A-T-E-S, which some people use interchangeably with opioids. And opiates are actual direct natural derivatives from the opium plant. For example, morphine and codeine are opiates. They come directly from the plant, and they're refined and then used medically. Opioids are opiates that have been modified chemically in the laboratory to enhance their effectiveness or change some of their qualities. And there are what they call semi-synthetic opioids, which are oftentimes, like, for example, examples of that would be oxycodone or hydrocodone. They're semi-synthetic, so they have a portion of the original component of the opiate. And then there are completely synthetic opioids, like fentanyl. But so the category of opioids is a very broad category. Heroin, for example, which is diacetylmorphine, is an opioid. Heroin is just a brand name that was given to it when it was developed in the 1890s by Bayer. But when people hear in the news opioid overdose deaths, they're in their mind thinking, understandably, that this is, oxycodone that a doctor prescribed. But in fact, according to the government's own data, in the most recent year we have, 2017, 3/4 of overdose deaths related to opioids are deaths from fentanyl and heroin. And of those deaths that are from prescription-type opioids, I should mention that the fentanyl that's involved in the overdose deaths in this country, according to the Drug Enforcement Administration, is what's called illicit fentanyl. It's not fentanyl that's made by pharmaceutical companies for medical use, which in most cases is either an intravenous solution used in hospitals or a skin patch that you wear on your skin that slowly absorbs over a few days. That's called, the common name of that is Duragesic. Some people out listening might be familiar with that. The fentanyl that's involved in the overdose deaths, almost all of it, according to the government, is coming in a powdered form from laboratories, mostly in China, but also now in Mexico. And oftentimes it comes in through the mail. It's coming in through airports and ports of entry. It's very difficult to detect. People are ordering it on the dark web and then receiving it, and then drug dealers are using things like pill presses to make it look like a prescription-type opioid, like Vicodin or Percocet, and then selling it to non-medical users on the street, or they're using it to as an additive to heroin to make the heroin more potent. because as we all know, when it comes to prohibition, prohibition tends to incentivize the development of more potent forms. So it becomes easier to smuggle in smaller amounts, and also you can get more. You could subdivide it into more pieces and get more bang for your buck if you can take the risk of smuggling. So anyway, when we hear opioids in the news, there were 49,000 opioid-related overdose deaths in 2017. Everybody's thinking that's from prescriptions that doctors wrote. Actually, people who out of those 49,000, if you take away people who were found to have a prescription-type opioid in their system that was mixed with other things like cocaine, heroin, tranquilizers, alcohol. If you just eliminate that, the percentage of opioid-related overdose deaths in 2017 were less than 10%. So everybody's thinking when they
okay, so what we have...
Yeah. Go ahead.
What we have so far, we have learned that opioid doesn't tell you when you read the word opioid in the media, or when you hear the word opioid or read it in the media, you know nothing about what the story is about, because an opioid is a label that could describe either a prescription drug manufactured under the regime of a licensed drug manufacturer with all of these quality controls. That's at one extreme, prescribed by a doctor to a patient because a doctor has decided that patient needs this prescription. That's one label, that's one classification of the opioid you're reading about. And then the very same word could describe an illegally manufactured fentanyl or similar substance manufactured illegally under no controls whatsoever, illegally brought into this country and sold on street corners or whatever the distribution channels are, all illegally. Both deaths, if there is a death from that opioid, would be classified the same way in a newspaper article, but they have almost nothing in common except some chemical similarities. Okay, so that's the world. It's a world where there are two extremes, where the word opioid means two extremely different substances. Now, Jeff, a lot of the attention that the media has been given, and then the government has been given, is to, we'll start with the prescription, the drug, the opioid manufactured under the regime of a drug company with procedures that all of which are controlled by the drug company and controlled by the government and are sold pursuant to a regime, the prescription regime in this country, and prescribed by a doctor. And so doctors prescribe opioids. Now, Jeff, just for a second, why would a doctor, what is the illness, what is the malady which the doctor is hoping to cure with the prescription of opioid? Why opioid and not something else? What does opioid do?
Opioids are very effective for managing pain. And we've known this, of course, from way back till the days of antiquity. Even in the days of the ancient Roman and Greek doctors, we've known opioids, they relieve pain. So when we're dealing with, it depends on the circumstance. It could be acute pain, like post-operative surgical pain, or you broke a leg, or it could be chronic pain. There's a lot of patients in chronic pain. So opioids are effective in treating pain. And I should add, another misconception out there is that the people who are dying from prescription opioid overdose deaths, they think that this is from doctors prescribing pain medicine to them. But the overwhelming majority, in fact, up to 97% of people who die from prescription opioid overdose deaths have multiple other drugs in their system, like alcohol and cocaine and heroin, and they are actually not using it under a doctor's prescription for medical purposes. They're using it for other purposes. They're not what we call non-medical users. Although a lot of surveys of them are saying to surveyors that they're self-medicating for their own pain, and that could be either psychological pain or physical pain. So if you look at, no matter how many studies have been done by peer-reviewed studies by researchers since as far back as we can go, prescription opioids given in the medical setting have an overdose rate of anywhere between 0.01% to 0.05%. It's very comparable. For example, the mortality rate from taking daily opioids, and this is not controversial. You can look at any study you want to. The mortality rate from taking opioids on a daily basis is roughly equivalent to the risk you're taking by taking an aspirin a day for cardiovascular health, or being put on a blood thinner because you have atrial fibrillation. It's relatively safe. Now, other pain relievers actually can be more dangerous. So, we're hearing a lot in the news about we should put the patients on non-steroidal anti-inflammatory agents like ibuprofen. Well, they have a lot of risks, too. In fact, that they could kill the kidneys. They could affect your bone marrow. Tylenol, which has not been shown to be effective for the treatment of pain, but it's only been shown to be effective for bringing down fever. Tylenol in high doses could kill the liver. So in many respects, the risks you're taking by being on relatively high dose non-steroidal anti-inflammatories or Tylenol over a long period of time are greater than the risks associated with taking an opioid in a medical setting with the supervision of a healthcare professional who tells you how to use it properly. Because a healthcare professional will tell you, don't take this with alcohol. Certainly don't crush it and snort it, or crush it and inject it into your veins. This is non-medical use. So what's happening now is between all of these misperceptions, the government has gotten into the action. Politicians, of course, are always trying to, quote-unquote, help us and, quote-unquote, fix our problems. So I think wasn't it Ronald Reagan who said the most frightening words are, "I'm from the government, I'm here to help you"? So they're passing all these laws based on these misconceptions that are in most states now. In my state of Arizona, they're deciding if you're prescribing an opioid for an acute pain, you can only prescribe X amount.
Well, Jeff, let's go back for a second, and let's go one step at a time. So first what have we learned so far? We have learned that opioids, when prescribed and when taken as prescribed, do good and statistically have an insignificant, almost zero adverse effect when prescribed by a doctor and when taken as prescribed. And I'm quick to add, although I'm not a doctor, obviously, I dare say any prescription drug which a doctor prescribes, if you gulp it down like an M&M and take well beyond the dosage your doctor recommends, and if you use it for the wrong purposes, it will harm you. So the fact that taking an opioid prescription drug not as prescribed, but misusing it will harm you, that's not a headline. That's true of everything. Gulp down enough aspirin and you will die. So the fact that the misuse of a drug will harm you is hardly the reason for governmental intervention. So how did the government get involved to begin with? Since an overdose of aspirin can kill you, why opioids? What was the politics? And why do we read so much about the linkage, the alleged link between doctors prescribing opioids and death in back alleys?
Well, Bob, if there's one other, in order to answer that, I have to clear up one other misconception out there, and that's dependence versus addiction. Now, opioids are a class of drugs like many other types of drugs, that if you take them for a prolonged period of time, your body physiologically adjusts and you become what's called physiologically dependent on it. So that if you try to suddenly abruptly withdraw the drug, you'll get, in case of opioids, very extremely hellish withdrawal symptoms that could last several days. But many drugs have that. For example, beta blockers, which people are familiar with because it's often prescribed, for example, for a high blood pressure. If you've been taking beta blockers steadily and you suddenly need to go off that medicine, you have to be tapered off. If you stop abruptly, you can get a fatal withdrawal from beta blockers. Tranquilizers, antidepressants. There are numerous types of drugs that you get physically dependent on. Now, that's not the same thing as addiction. And unfortunately, well, first of all, none of our politicians and people in the press would say you're addicted to a beta blocker. But they would say you're addicted to an opioid because they equate dependence with addiction. And in fact, addiction is, and again, this is not controversial, the official description of addiction is compulsive use of the substance despite negative and self-destructive consequences. Now, that's not the same thing as dependence. So when a person's been on an opioid for a long period of time for, let's say, they were in a hospital for 2 months for a major trauma, and they were in exquisite pain, they had a lot of bony injuries, and they had to be on high-dose opioids to control their pain, and then they're released from the hospital, they can't, if you try to abruptly take them off the opioids, they're going to get horribly sick, sometimes as bad as the pain they were experiencing or worse. So they need to be maintained on opioids and gradually tapered off. And it could take sometimes several weeks to taper them off. But they're not addicted. In fact, as a surgeon, I've had patients tell me when I'm discussing their proposed surgery with them, they'll ask me, what were you planning to prescribe for me for pain after the surgery? Because the last time I was on an opioid and I went into withdrawal, it was a horrible experience. I don't want to go through that again. That's not the kind of comment that would be made by a person who's addicted. The kind of comment made from a person who's addicted is somebody who wants that. They want to go through they want the pain. I'm sorry, they want the opioid because they're craving it, because it's a compulsive behavioral disorder. But unfortunately, again, our media and politicians equate the two. The actual addiction rate with opioid use is roughly 1 to 3% based on the research, but as opposed to dependency. But it's that understanding and misunderstanding that, again, has kind of fueled a lot of the bad laws that are being passed and the bad policies that are being implemented in this country.
So, Jeff, we start with a doctor practicing medicine and concluding that based upon his training or her training, the patient would benefit from a prescription for OxyContin or one of those other opioid-based pain killers. So, and that's done in the privacy of a doctor's office, as benign an exchange between doctor and patient as there can possibly be. How did that start to draw the attention of government? And Jeff, we're going to go to break in a second, but when we come back, I'll ask you to please explain, of all of the interactions between doctor and patient in the privacy of a medical suite or a medical office, why did opioids all of a sudden draw the attention? Since, Jeff, as you have pointed out, there is nothing threatening about the prescribing of a painkiller, an opioid painkiller, to cure pain. That is the right thing to do, and there's nothing which ought to be grabbing headlines. So when we come back, since, Jeff, you have such insight because of your work at Cato, tell us the politics of how government discovered this as something they should be involved in to second guess the prescription of opioids by a doctor. It's an important question, Jeff. We can't wait for the answer. We'll have to wait for 30 short seconds. We'll be right back.
Red states versus blue, urban versus rural. As federal government keeps growing bigger, we the people are getting angrier when our side doesn't win. Are we at risk of becoming a nation permanently divided? In his latest book, Power to the States, How Federalism 2.0 Can Make America Governable Again, talk show host and author Bob Zadek explores factions and divisions that are inevitable and a solution that's been there in the Constitution all along. Power to the States features conversations with top scholars, statesmen, and a sitting state Supreme Court judge. Bob and his guests show how liberals and conservatives are rediscovering the virtues of federalism, where states become laboratories of democracy and citizens vote with their feet when they don't like what government is doing. Order your copy of Power to the States at bobzadek.com today. Zadek. A house divided can't stand, but healthy competition between the states can make America more prosperous than ever before. Power to the States, How Federalism 2.0 Can Make America Governable Again. Available now at bobzadek.com. That's bobzadek.com.
Welcome back to the Bob Zadek Show, the longest-running live libertarian talk radio show on all of radio, always live. Thanks so much for listening this Sunday morning. We are today and always the show of ideas, never, ever, not once the show of attitude. This morning we're speaking with my dear friend, Dr. Jeffrey Singer. Jeff is a practicing general surgeon in Arizona, and he also is a senior fellow at Cato, working in the area of the Department of Health Policy Studies. And Jeff has, and the country is so much better for Jeff doing so, Jeff has been studying the politics of opioid prescription and what the government is doing and how the government is interfering with the very important and very private relationship between doctor and patient. So, Jeff, before the break, I asked you to discuss for us after the break, which is now, the what has caused, how did that interaction, the prescription of opioids by a doctor, because it is the medically best thing to do, how did that get the attention of government? And Jeff, far more importantly, what action and what policies and laws has the government been taking to interfere with the special relationship between doctor and patient? And the third part of my question is, how does that harm us?
Okay, I'm going to have to give a little brief historical background. I'll be very brief. But basically, when back in the 1970s, when the war on drugs was really kicked into full gear by President Nixon, doctors, patients, the entire public were told to have this tremendous fear of any of these drugs. We were given this myth that just, one dose of the drug and you're hooked for life. So doctors were taught this as well. So throughout the 70s and into the 80s, we doctors were extremely stingy with pain medicine. And oftentimes when we offered pain medicine to patients, the patients were afraid to take it. And so there were many, many studies coming out, starting in the early 70s, going through the 80s into the 90s, showing that, there are many cases where people are not getting adequately treated for pain, and based upon what we know about opioids, like we spoke about in the previous segment, we're overreacting in fear. We should be much more generous in treating pain. We should take pain more seriously. We should ask people if they're in pain. We didn't even used to ask. So by the early 90s, the government agencies, the National Institute on Drug Abuse, all respected institutions were encouraging doctors to relax their restrictions on giving pain treatment. And by the late 90s, we were following suit, and patients also had learned to not have that fear. So we saw a lot more prescriptions of prescription-type opioids taking place as the late 90s came about. Now, step aside from it. A recent study came out from the University of Pittsburgh, a fantastic study. They went through government data going back to the 70s. And what they've learned is that the non-medical use of both licit and illicit drugs has been on a steady exponential increase since the 70s, and shows even now no sign of stopping it. The trends are not stopping. The only thing that's changed over the years is which drugs come in and out of vogue as the drugs of choice of non-medical users. So that in the late 70s, early 80s, it was heroin. Then cocaine became really big in the 80s and into the 90s. Then it was prescription painkillers like Vicodin, after oxycodone, after OxyContin was invented in 1996, which is concentrated oxycodone, that became a popular drug for non-medical users to use because if they were able to obtain what people call diverted, which means, diverted from the normal stream, either stolen from a medicine cabinet or from a warehouse or whatever. They're able to obtain a diverted OxyContin and crushed it and either injected it or snorted it. They get a much bigger dose than if they did that with an oxycodone pill because it was concentrated. So, and now, of course, we're up to fentanyl and heroin are the vogue. So by the late 90s and into the early 2000s, the most popular drug of abuse was prescription painkillers. Now, there's a lot of, again, history. When people were dying from crack cocaine.
But Jeff, let me mention one thing. You said the abused drug was prescription painkillers, but I want to remind the audience that this was not through prescription. The drug itself was a prescription drug, but it was not a prescription. It was gotten outside of the normal prescription channels, and that's very important to telling this story.
Right. It was called it's what they call diverted prescription opioids. So, we saw less attention to the crack cocaine crisis or the, other drugs back in the 70s and 80s, and maybe that's because most of the victims were not white, middle-class, middle American kids. But by the early 2000s, diverted, stolen, whatever, prescription painkillers were starting to be used non-medically throughout the country in middle-class, suburban communities. And of course, because this was gotten through the black market prohibition, because it's prohibited except through a doctor's prescription. Prohibition, of course, incentivizes, brings out the worst in people. So it incentivized certain doctors to operate what were called pill mills, where they really weren't treating patients. They were just basically for a fee giving you huge prescriptions that they knew you were going to use non-medically. Or they even had deals with drug dealers. There was a lot of them where drug dealers would pay somebody to go to a doctor that they had an arrangement with, who would then write them a huge prescription and then get it filled at a pharmacy that the dealer had an arrangement with. So there was that. There were doctors arrested. There's one in Orange County who was arrested for writing prescriptions, going to a Starbucks and writing prescriptions for $600 for oxycodone to people who wanted to abuse it. So this was all outside of the realm of medical practice, okay? And, of course, when it started affecting, middle-class suburban America, now it started getting the attention of politicians. So now we have a crisis. It didn't seem to matter when, IV drug users were dying from heroin overdoses in the inner city because that was a different population. But now it's affecting, us. So now we got to get involved. So they came to the conclusion that it was the doctors prescribing the opioids that was causing the overdose crisis. Now, like I said, there were some unethical doctors who were basically profiteering in the black market. These were not mainstream doctors. These were a tiny minority of doctors. And I would argue that if you want to know what caused them to do that, it was the lure of money provided by drug prohibition. But set that aside. Once they made up their mind that that was the cause, they started clamping down on the ability of doctors to prescribe. The dose part came later. First they wanted to stop these prescriptions because the number of prescriptions had gone up tremendously between 2000 and 2010 because, again, doctors were encouraged to be much more generous in treating pain, and patients were encouraged to not be afraid. But they made this mistake, the politicians, of equating the cause of the overdose crisis with those prescriptions. I published a study in the peer-reviewed Journal of Pain Research in February, along with two other authors. We looked at government data going back as far back as it was available from the National Survey on Drug Use and Health, and we found that there's absolutely no correlation between the number of prescriptions written and, using their terminology, past month non-medical use of a prescription pain reliever, and also past year diagnosed with prescription pain reliever use disorder. Throughout the entire 2000s, as the number of prescriptions actually doubled, the past month non-medical use of prescription pain reliever and the past year diagnosed with use disorder stayed a straight line, flat line. So there was no relationship. But nevertheless, the policymakers and the press, and they're in a little bubble, decided that it was the doctor's prescribing that caused this. So they started clamping down by having these monitoring boards. Every state's got these monitoring boards that are monitoring how much we prescribe. And if we prescribe what they decide are too many opioids, we get a visit from the government. And a lot of us now are getting licenses revoked, going to jail. So the doctor has cut back dramatically. So since 2010, the number of high-dose opioid prescriptions has dropped more than 60%, and all opioid prescriptions have dropped about 30%. Yet the overdose rate has skyrocketed. What happened is, as the availability of diverted prescription opioids became dried up, and it became less available, what happened is the population and growing population of non-medical users just migrated over to the next available thing, which was easier to get, which was at first heroin. And now they're dying from heroin and fentanyl overdoses. The data suggests that most of the people who are dying of heroin and fentanyl overdoses are not preferring to use fentanyl. The fentanyl is being mixed in with the heroin to increase its potency and to facilitate its smuggling in smaller amounts. And people are actually wanting the heroin because fentanyl, it gives them a different experience. Some like it, but they're dying mainly because the fentanyl has made the heroin they're injecting so powerful that they're overdosing from the fentanyl. So all that's happened, based upon this misunderstanding of what's causing the problem, the patients who need the pain medication are suddenly finding they can't get it. They're being, after an operation, they're being told take a Tylenol or take an Advil, or they're being given prescription painkillers only for like a few days when they need it for maybe 2 weeks. And that's happening. And doctors actually are so frightened because there are horror stories around the country now that some of them are just saying, I'm not prescribing any opioids at all. So we're going back to almost pre-1970s treatment of pain, which it's almost primitive, the way we're starting to treat patients in pain. And in the meantime, while we're hurting those patients, all it's done regarding the overdose crisis is risen the overdose rate. So when they started making these interventions, roughly half of the overdoses involved in your system a prescription pain pill, again, mixed with these other drugs. By 2017, less than 10% involved the prescription pain pill without any drugs, and about 25 to 30% had it mixed with things. So all we've done is we've created the next crisis, which is the fentanyl and heroin crisis. But the studies, the one from the University of Pittsburgh, would suggest that this is a trend that's continuing. More and more people in this country, and by the way, it's not confined to the United States. We see this in Canada, we see this in Australia, we see this throughout Western Europe. They have an overdose crisis as well. And it's interestingly, right now, fentanyl is the number one problem in Europe, and as well as heroin, as well as in Canada and Australia. So we could, if we want to get really philosophical, and this is beyond my area of knowledge, there are obviously changes taking place in society where a growing number of people are non-medically using licit and illicit drugs. Maybe there are more people who are troubled. There's reason to believe or suspect a lot of people are self-medicating, and I'm not necessarily saying self-medicating for pain, for physical pain. It could be for emotional pain or psychic pain. And when you talk to people with substance abuse disorder, they'll often tell you that when I'm using heroin, it takes me to this place where all the things that make me not want to be alive don't seem to matter anymore. They sort of it numbs me. So there's something. This is complicated, and there's no simple explanation, and there's no simple answer. But I think it was Mencken who said that for every single problem, there's a simple explanation with a simple solution, and they're both wrong. I don't know if I'm getting his words exactly, but that's basically what he said. Now, what's happening on the state level is not only are the states monitoring and limiting how many numbers of pills you can prescribe because they've become convinced that it's that the number of prescriptions is somehow related to the non-medical use rate, but they're also restricting the number of dosage. And again, that's based on bad science. The CDC, the Centers for Disease Control and Prevention, back in 2016, issued guidelines. Now, guidelines are not orders. They're guidelines. They're supposed to guide you. And they started out in the opening of their guidelines by saying this is not meant to be prescriptive. These are their words. This is meant to be suggestive. And they also said that everything we're about to tell you is based on what they called type 4 evidence, which is the weakest evidence. Much of it is observational and anecdotal and may turn out to be wrong. They actually said that. And then they said things like, in many cases when treating a person with acute pain, 5 days worth of prescription opioids is sufficient. And also, in many other cases, 7 days is sufficient. Well, as a doctor, hearing that, number one, this is type 4 evidence. Number two, this is suggestive. And number three, in most cases, this is sufficient. I'm saying, well, tell me something I didn't already know. And thank you very much. I'll kind of put that on my good-to-know list. In the meantime, I'll continue to prescribe my pain medicine to my patient based upon what I know about that patient and the situation. And by the way, in their conclusion, they said that. They said the doctor knows best and should obviously weigh the risks and benefits, and they know their patient. But the politicians don't understand nuance. You know, policy is hard to do nuance with. Plus, 30-second sound bites or 10-second sound bites or 160-word, 60-character Twitter tweets, you can't do nuance with that. So they started passing laws. In my state, they said, okay, no more than 5 days. If I have a patient who's in pain, I can't give him more than 5 days' worth. Then there's some other studies that suggest, and again, it's not conclusive, that they see more people overdosing on opioids when they have more than the equivalent of 90 milligrams of morphine in a day of whatever their opioid is, than less than, okay? Nevertheless, they point out in their studies there are people who are on the equivalent of 200 milligrams of morphine a day who don't overdose because, like I said in our earlier discussion, there's a very low potential for overdose in a medical setting. Plus, when you've been on it a long time, you develop tolerance to it, so you could tolerate higher doses. But nevertheless, no nuance. So most states have passed laws, and now pharmacies passing on. Medicare is putting in a requirement that if a doctor prescribes a dosage for a patient that exceeds 90 morphine milligram equivalents in a day, they have to get special permission in order to do that. So in other words, we have all these non-doctors using ham-handed ways and one-size-fits-all interpretations of what they were told originally was not meant to be taken as prescriptive and was not conclusive and was very, very was based on very weak data that may turn out to be different. And they took that and they made it into statute. And now,
just to explain what Jeff has said, not that it needs explanation, of course, but notice what we have. We have a patient, a school teacher, who has severe back pain, where the doctor says, I have the perfect, not cure, but I can alleviate your pain so that the quality of your life will be materially better. I have the perfect solution, but I am not allowed to give it to you, even though the fact that I prescribed this painkiller for a longer period of time than government thinks is necessary, that fact has no adverse effect on you or on society. There's no effect to anybody but the doctor in a totally private decision where the patient will benefit. The doctor lives in fear of losing her license or worse by prescribing what's best for the patient. And that's because the government has decided to invite itself into a doctor's office and to second guess the doctor. And remember what Jeff has said, there is no societal benefit This is just cruelty where the government says a doctor cannot prescribe to her patient what the patient needs, and the doctor determines to be the best. And that's the cruelty, the abysmal cruelty of it all. And it's based upon no science, not even junk science. To call it junk science would be to give it a compliment it doesn't deserve. It's based upon witchcraft, and that is our government interfering with the medical profession and what doctors determine to be best.
Yeah,
and one other comment on what Jeff has said. Go ahead.
Well, it's based upon this false notion that it's our prescribing opioids to our patients that's creating this overdose crisis. They're ignoring the fact that 75% of the overdoses are heroin and fentanyl, and less than 10% are just prescription painkillers without anything else. They're ignoring that. They continue. So making my patient who needs relief from pain go in pain is not going to make one IV heroin user decide not to shoot up. But they're just hell-bent on going full speed ahead. It got to a point where the CDC, about 2 months ago, issued what they call a clarification, where they actually said, but it's too late because it's already in statute, but they actually said, you guys are misinterpreting our guidelines. We never said that these were fact. We said these were guidelines and that doctors should use their best judgment. You're using it the wrong way. They actually said that. The AMA has complained about it. But to make matters worse, for example, in California, where you're broadcasting from, they passed a law so that now if a person dies of an opioid-related overdose death, and they're found to have a prescription pain reliever in their system, if they could trace who the doctor was who wrote the last prescription to that person, that doctor can be charged with homicide, as well as...
Oh, my God. You have to be kidding.
The board of
that can't be...
to go over their license. And possibly...
That can't be the case. You have to be kidding.
No, I'm not kidding. That's the law in California now. They can be charged with I think it's involuntary manslaughter. I'm not sure about the exact legal status. And also, the licensing board is required to review them and possibly take their license away. This is if an opioid-related overdose death, you could trace the last prescription that person received, okay? And, of course, as you know, there are patients who are non-medical users who go in and fake a pain in order to get a prescription. And there are also non-medical users who steal out of somebody's medicine cabinet a prescription someone else had received, and, of course, there's a doctor's name on that prescription. So this is just continued to fuel the fear. Many of them are saying, you know what, I'm not prescribing any opioids at all. I just don't want to take that chance. I can understand that, but this is not helping patients, and it's certainly not making the fentanyl and heroin users stop using.
I want our audience to take a step back and just do the mind experiment. But imagine you are in the kind of pain each and every one of us has experienced. Back pain, nerve pain in your legs or in your back. Think back to that experience. Imagine sitting in a doctor's office pleading with a doctor, I need help. I can't function. I can't function in my family, in my job. My life is hell because of the pain. And the doctor says, I have the perfect solution, but I'll go to jail if I prescribe it. So I have to say no. Imagine how you would feel when you left that doctor's office in the same pain, and the professional you have paid to help you is prohibited under pain of imprisonment if he prescribes the drug that he knows you need and you know you need, and you are denied it. Imagine the extremes you will go to get that drug just to seek relief. And one more comment. Jeff mentioned this guideline, this guidance issued by CDC. Regular listeners to my show will recall that the administrative state uses guidelines with great effectiveness. Remember back to 2011 when President Obama's Department of Education sent the famous Dear Colleague letter to school administrators reminding them that they have to take claims that a woman was raped seriously, and if they don't, there's a danger of them losing their federal aid. It was a Dear Colleague letter. It was a guidance letter. It caused the entire university system in America to start to violate the rights of accused for a decade, almost a decade, until that was fixed by President Trump's Department of Administration. So guidance letters are sinister because they are issued without any kind of administrative controls, and they have a profound effect, as Jeff has explained. Now, Jeff, we only have a minute to go. Tell us the work that you and Cato are doing to try to bring this to the attention of legislation. We only have a minute. To the legislators.
Obviously, we're publishing numerous studies, policy briefs. We're having conferences constantly at the Cato Institute. We make sure we feed this information to legislative staffers and to senators and congressmen, and that's what we can do. It's our job to publish studies and reports that tell the truth and that guide what the policy should be. And so that's what we continue to do. We're having a conference at the Cato Institute on October 3rd, and it'll be live streamed. That's going to examine how these prescription drug surveillance boards, they call them prescription drug monitoring programs, which exist now in all the states, whether they've had any effect. I could give you a little, trailer is, or a hint. This is a spoiler alert. There's no evidence. They have had an effect of getting the prescription.
Jeff, we're running out of time. Jeff, the audience is not going to be able to hear you. So, Jeff, I invite our listeners to follow you at Cato and to follow the work of Cato. And, Jeff, thank you so much for your wisdom this Sunday morning.
Thank you for having me. It was a pleasure.